Adolescence and trauma-focused cognitive behavioral therapy. 4,549 children ages 0 to 17 were studied by the U.S. Department of Veterans Affairs. 60.9% had either witnessed or experienced some form of victimization in the past year. Lifetime prevalence of this exposure increases by a third to a half of that 60.9%. Staggering numbers, right? With that being said, adolescent health can be determined by environmental or life situations, according to a study by Jensen and others from 2014, which we will look at closer in a few seconds. Because of this, any type of trauma to children and adolescents can potentially have a large negative impact for the rest of the lives of such victims. Prevention and/or early intervention is key to improving or maintaining good health mentally and emotionally for these young people. On top of this, Healthy People 2020 has established adolescent health improvement as one of the overall goals of the country as far as healthcare goes. This should be viewed as another great motivator to find out how we as healthcare professionals can best serve adolescents who have suffered at least one traumatic experience in the past. So, interventions. Quick breakdown of the interventions being studied to help improve or maintain mental health of adolescents. Cognitive behavioral therapy, or CBT, focuses on exploring relationships among a person's thoughts, feelings, and behaviors to uncover unhealthy behaviors and thought patterns and how they can be causing self-destructive beliefs and behaviors. Now, trauma-focused CBT, it's a component-based treatment model. It incorporates trauma-sensitive interventions that are going to go along with family and humanistic principles and techniques, and this is going to be specified to the actual traumatic event that took place with the individual. So, very individualized care going on with the trauma-focused intervention. So study one is by Jensen et al., which is a randomized controlled trial of 156 youth ages 10 to 18 in Norway who had experienced at least one traumatic event with significant post-traumatic stress reactions. The intervention group was TF-CBT, which received 12 to 15 sessions with a trained therapist of TF-CBT. The control group received treatment as usual and received whatever type of treatment that the therapist chose to deliver. Effectiveness of treatment was measured using the Child PTSD Symptom Scale, or CPSS, which is a self-report questionnaire developed for children between the ages of 10 and 18 that meet criteria for DSM-4 with a 4-point scale in which higher scores mean more PTSD symptoms. In TF-CBT group, there were significantly decreased scores or symptoms of PTSD. The clinician-administered PTSD scale for children and adolescents, or CAPS-CA, which measures trauma exposure intensity and frequency of the symptoms, using a 5-point scale, and increased scores again mean increased symptoms of post-traumatic stress. 18.2% met criteria for PTSD after the TF-CBT group and 36.2% in the treatment as usual. So there was a higher percentage still with post-traumatic stress symptoms after the treatment as usual, which was a significant difference. So study number 2. So it's by Goldbeck, Moose, Sascher, Tudis, and Rossner. This is an RCT that took place at 8 German outpatient clinics of 159 youth ages 7 to 17 with exposure to one or more traumatic events. Intervention group was once again TF-CBT, which consisted of 12 to 15 sessions with trained TF-CBT therapists. The control group was actually a waiting list group this time. It unfortunately can be a realistic situation when it comes to interventions for this. So scales used to measure effectiveness for the CAPS-CA, the UCLA PTSD Reaction Index, Child Post-Traumatic Cognitions Inventory, or CPTCI, and Children's Global Assessment Scale, or CGAS. Results from the combined measuring tools revealed a NOVA of significant interaction of group and time, P equals 0.001, which indicates a superiority of the TF-CBT group. 34 of 57 that met PTSD criteria no longer met criteria at 4 months. 24 of 63 with previous PTSD at baseline no longer met criteria in the waiting list group. A particular great finding in this study was that there was no dependence on the experience of the therapist when it came to results of the treatment. So, utilizing findings. The results from both studies agree that TF-CBT is a successful intervention for adolescents who have suffered a traumatic event in the past. There is strength in the studies because of the sample sizes and diversity of past experiences, especially in Jensen. Goldbeck, Moose, Sasher, Tudis, and Rossner found the important factor that there was no dependency in one experience of deliverers of TF-CBT. The fact that the study took place in 2 different countries also suggests a global success in this intervention. Implementation. This means that as healthcare professionals who hopefully want to keep up with the latest evidence-based interventions, we can trust TF-CBT to be helpful to adolescents who have had a traumatic experience before. Appropriate setting. The beauty of TF-CBT as implemented in both studies is that it works well in an outpatient or community setting since it consists of 12 to 15 sessions, which can include the patient and/or parents or other family members as appropriate to the case. That being said, the feasibility of the intervention gives providers even more reason to utilize this great intervention. So we can help change the health of adolescents mentally, emotionally, and even physically for the better by implementing this intervention of TF-CBT to the appropriate population and help reach not only Healthy People 2020 goals, but also hopefully individual goals in our future practice. So if you have any questions, please feel free to reach out to me in discussion board.